Okay, we're recording and now we'll share again. Yeah, it's thank you for asking that, and that's perfectly fine. It's not that I don't like to record it. I just don't like to give people the idea. And let's see how many. Oh, I'm going to stop recording just for 1 second. Yeah, most of you are here. That's great. I'm really, really happy. 57, 6 of you are not, but 57 are. I'm sorry that maybe up to a third of you sort of disappear in the last hour, and I'm really sorry about that because I just don't know how you can learn and be comfortable with the material without this last hour of problem solving. And I didn't want to give the illusion that simply looking at somebody else's answers will accomplish that for you, but this is a special circumstance, so we're good. Okay, let me share the screen again, or make it big, I mean. Okay, there we go. So moving on. Here, number 6. The formation of a bolus requires continuous general sensory information from the anterior 2/3 of the tongue. What cranial nerve is responsible for that feedback? Anyone want to throw in a guess? An educated guess, of course.
The tongue muscle, the hypoglossal.
Isn't it E, branchiomotor component of the glossopharyngeal nerve? Oh no, that's wrong. It's
The
posterior.
formation of a bolus requires continuous general sensory feedback from the anterior 2/3 of the tongue. Which cranial nerve is responsible for that feedback? Oh, it is the mandibular division, but not the branchial motor. Oh, that's wrong. I have the wrong answer up here. It's the mandibular division, and that subserves general sensation for the anterior 2/3 of the tongue, but I erred in putting branchial motor. That would be somatic sensory or somatic afferent component of the mandibular branch of the trigeminal nerve. So I'm sorry about that. B, but somatic sensory. Okay. During chewing and oral preparation of a bolus, the muscle tone of the facial muscles keep the buccal cavity from being filled. Which cranial nerve serves the needs to be intact in order for the buccal cavity to remain? And it is the branchial motor component of the facial nerve. You need, the facial nerve does number 7. Number 7 does the whole face, and including your cheeks, and you need to have tone in it. And the way you get that is from the branchial motor component of the facial nerve. All right. Number 8. The pharyngeal swallow response is initiated when the bolus is pushed by the tongue through the oral pharyngeal port. The resulting action potentials are transmitted to the nucleus solitarius through what nerve? Anyone?
Would it be C, the glossopharyngeal nerve?
It sure is, yes. Everything behind the oral pharyngeal port, as far as the sensory component for the swallow, is subserved by 9. And in fact, for our purposes, 9 doesn't do much else. It does have some other functions. But for SLP's thought process, it doesn't do much, except just that one little muscle, but you can't possibly test the stylopharyngeus muscle differentially. So we just think of it as a sensory nerve, really. Okay, the brainstem swallowing center is made up of all of the above: the rostral end of the nucleus solitarius, the nucleus ambiguus, and the surrounding parts of the reticular formation. They're all somehow wired up and programmed to receive the sensory information from the nucleus solitarius. As soon as that bolus crosses through the oral pharyngeal port, down goes the trigger, basically, in the form of action potentials carried by 9 to the nucleus solitarius. And that's the afferent side of the whole thing. And then all the circuitry kicks in to send out commands to the different muscles involved in the steps of a pharyngeal swallow response. in a certain sequence. Pretty amazing, really. And by the way, you're programmed to do that very early, long before birth. A neonate start swallowing amniotic fluid at around 12 weeks post-gestation, very early. The brainstem swallowing center is made up of, number 10. Adduction of the vocal folds during the pharyngeal phase of the swallow is most dependent on the function of which nerve? Anyone know? It is the recurrent laryngeal nerve. And that innervates all of the muscles that close the larynx, at least the vocal fold part of the larynx, I should say. All of the muscles, it innervates all of the intrinsic laryngeal muscles except for one, and that's the one that is involved in pitch regulation. So it's the recurrent laryngeal. And that is the completion of 10. So let me take that, let me just stop sharing. Well, I'll leave it up there. Does other questions? Are you ready to go on to the problems? Okay, let's go on to the problems. And I will stop sharing this screen and bring the problems up.
Like full disclosure?
Yeah.
Didn't even study for it. I was so busy studying for the exam.
Yeah.
Full disclosure.
Okay, I can understand. That seems like an effective strategy. Okay. Well, let's see. It sounds like you guys are not really ready to do this right now. Do you want to try some? You want to just, yeah, okay, let's do one. Let's do the first one. I do have the answers and I will post them right after class. If you guys don't have, but you can, I'm sure you can do it. So let's break you into small groups and spend 10 minutes, let's do 8 minutes, because I think you're kind of getting onto this. And I think in a small group, you can do number one pretty quickly. Let's try. So I will put you in groups now. I have to stop sharing for a moment. Okay. And I'm going to open the rooms and I'll circulate. Okay.
Okay. So I guess we're being recorded.
You guys, you guys have a leader
Oh,
or
yes.
somebody who's sharing your document. You need a paper in front of you guys.
Oh, right. We need a share screen person.
You need yeah. You don't have to call them a leader, but you need somebody with a piece of paper.
We should get the paper up.
Okay, all right. I'll come back later when you.
Oh, sure.
Bye.
At the right. Is he recording us? Are we?
Yeah, he's in here.
Oh.
I think, right? Oh yeah, there.
Oh, yeah.
Oh, I think you're muted.
Thank you. I was just saying, I don't know that I'm recording you. Maybe, I guess I'm recording the session. So I don't know if that's, if it goes with me wherever I go and records that or
Yeah,
not.
no worries. We're just looking through the notes real quick on
Okay,
chapter
sure.
7.
Yeah.
And here I know you labeled the steps for each one. So
Uh-huh.
like in this case, do you want us to, because we haven't really looked at chapter 7 yet, so you wrote it down, so I'm not sure, do you want us to write like the next step after like the glossopharyngeal nerve?
Sure. Yeah. Well, you could just, you could go glossopharyngeal nerve, and where's it go then?
I'll have to look at my notes real quick.
What nucleus is it going to head for?
Oh, the nucleus solitarius?
Yeah. So that could be your next step right there.
Okay.
Yeah. And then there you're going to have a second order neuron, and you want to think through, where does it cross? And then what's it go up in? What is it ascend? It's got to get to the cortex. And what does it go through? So nucleus solitarius, and you recall the decussations are generally, they're right at the level of the nucleus, whether you're talking about a motor system and descending pathways, or whether you're talking about ascending pathways. In this case, it's ascending. So you have the decussation right there, and it goes over and it joins the medial limniscus.
Oh, okay, fine.
Yeah, and now you've traced the medial limniscus a lot, so it's going to follow that. So
Okay.
you kind of have this done. The only thing that's a little different is it goes to the insula, and I never really talked about the insula. It's a small part of this cortex that is buried inside the Sylvian fissure at the side, and it goes there.
Okay, yeah, the insula's not in the.
It's in that one diagram. If you go to the diagram that traces the pathway from glossopharyngeal and 7 for that matter, all the way up, you'll see where it goes.
Is there a diagram on the chapter 7?
Well, there is in the notes. There is in the notes. I mean, in the
Mhm.
slides.
Okay.
Yeah, it's going to be with a chapter with the glossopharyngeal part of that, or maybe the facial nerve, because that's involved in taste too. 7 or 9.
Okay.
Okay, sure. I'll see you later.
All right, thank you so much.
Sure.
Okay. Story.
Not sure. Oh, hi, Professor.
Hi there, Evan. Do you
How
have?
you doing?
Huh?
Oh, how you doing?
I'm doing well. How are you doing?
Not very well studied for this. These
Oh,
questions,
oh
if I'm going to be
my
honest.
gosh. Yeah,
Sorry.
I don't know. I'm doing okay, but I feel your stress too. So
Yeah,
yeah.
I'm a tomato at this point.
Okay.
But,
Yeah.
So here we have.
So you're doing fine here. You got it to the nucleus solitarius. Let's see. Where's your glossopharyngeal nerve? Posterior.
Oh, that's where we're going. Sorry.
Yeah,
That's
plug that in right up after the tongue. The right. Is it the right?
Yes.
Oh yeah. So it's the right glossopharyngeal nerve. Then you got synapsing in the solitarius, and you have it decussating. Perfect.
Okay, but our question was, does general sensory information go into the medial limniscus, Or is that
Oh.
just general? Or
Yeah, this pathway does too.
okay, so special sensory goes in there as well.
Well, I don't know about all special sensory. No, I'm not,
Oh.
not all special sensory, but this one does.
Okay, for
Yeah.
sure. A decussate to the right, and then
Medial lemnis and joins the medial lemniscus. And then it goes up in the very, very familiar pathway that you know, the medial lemniscus, where it goes all the way up to the cortex. But this time it's going to go to the insular cortex. Check out that one diagram of, I believe it is in the slides. And it's a diagram of the central pathway for the glossopharyngeal nerve.
oh, okay.
You'll see exactly where it goes.
Do you mind if I share my slides with you to just like
No,
confirm?
not at all. I could share mine with you too, find it, but let's find it.
Is it this guy?
No,
No, okay.
I think it's later. Yeah, keep
Yeah,
going.
okay. That's the vagus.
Oh, darn, no. Okay, go back because we've gone past it. Maybe it's for 7. Because 7, once you get to the nucleus solitarius, follows the same pathway.
Oh, this one?
No,
Oh, and that's the vestibular cochlear.
no.
Okay, sorry. Hey there.
Oh, okay, not that one.
Guy.
No,
This one?
let me, no, it's not that one. Let me look at my slides. I mean, for some reason, it'll work better for me if I just look at my slides.
That's a good idea. Thank you. Sorry.
Yeah. Oh, you know what? I'm sorry, it's chapter 5.
Oh, okay, okay.
You know, that's a sensory, it's all sensory and it's got that central pathway.
Mhm.
But what, you just put the insula and then check out that slide later, or if you have
Okay.
time like that. Yeah, okay.
Perfect. Thank you, Professor.
Okay, bye.
This is, chapter 5 there. Cool. Trying to see if we can find it in chapter 5.
Did you find the exact slide yet?
Yeah. And then to the
And then it's going to go to the
left.
to the left placentral gyrus.
Yeah.
All right, I think that's it.
I think so too. I mean, it looks right to me.
Well, I'm sorry, we're at the, no, I see that we're at the left. You know what? I think I got it backwards. I think I'm dyslexic right now. All right, because the left,
No, I
Oh,
think
it
you're
was
good.
on the left, so it should have been on.
it should be the
Oh,
left.
it's
And
exactly opposite.
I think I'm dyslexic right now, so
Yeah,
I
I-
apologize.
the
So
exact way as
Okay.
you, Mark. I was very confused.
no, I think so this should be left.
Okay, but we got the right idea.
You just have to
Right,
just
I
switch
think.
everything around.
Interesting. Okay.
Okay, this is what we have so far.
You're doing really well.
Thank you.
You're doing perfect. Yeah, the gust, it goes to the gustatory area of the insula. So you're right. So that is not the precentral gyrus. I never really talked about the gustatory area of the insula. It's in the slide in chapter 5. But it's not in 7. It may be mentioned in the, I'm sure it's mentioned in the book, but I don't think I put it in a slide in chapter.
That's in the slide of chapter 5. I don't remember that name at all. And I went
Yeah.
through that 1,000 times.
Yeah, it's actually in the illustration, which shows the central pathway all the way up to the cortex. That's where it is.
Mhm.
And then is it the right side or the left side of the
Oh,
thalamus?
well, it's starting on the to the left. Okay, so it starts on the right, then it decussates to the left. You got this all right.
Okay.
And then left side of the thalamus, and then through the internal capsule and to the gustatory area of the insula. Yeah, I don't know where'd you get that, because you already had it, gustatory area of the insula. How do you find that? Or did you just know it?
Power. I think one of the girls had the PowerPoints.
Okay, good. Okay, anyway, you did great. Can I call on you?
Yeah.
Okay. Just take away the post-central gyrus. And then if you have time before we come together, which we are going to do right away here. Are you group 5? What's your number? 5?
5.
Yeah. Okay, so okay. All right. Let's see. I'm going to leave the room and then end the groups here. Okay. Well, listen, first of all, I'm noticing you guys are going a lot faster because we did go just about a minute over 10. And most of you seem to have gotten to the end and are really picking up speed and insight and everything. So that's great. And I'm somewhat arbitrarily picking number 5 group because they do have it done. And as do others, I know that. So if you wouldn't mind sharing your screen and we'll just take a look at it. So do you want to go through it for us?
Sure.
Okay, thank you.
We start off with the right glossopharyngeal nerve, or cranial nerve 9.
How do you know to start on the right?
Because the post-central gyrus is on the left most of the time, and it would be a contralateral.
Yeah.
And then we go to the right nucleus solitarius, and then at the second order neuron, we desiccate to join the left medial lemniscus.
Oh.
And then that second order neuron synapses with a third order neuron in the left side of the thalamus. And then the third order neuron ascends to the internal capsule to the gustatory area of the insula.
Yeah. Okay, that's very good. Or you could say the post-central gyrus. I mean, it does go there too, but the real tasting, does it say taste? Yeah, the tasting is done in the gustatory area. And I don't think I made much of a deal of that in the lecture. So if you missed that, don't feel bad. And actually I said post-central gyrus in setting up the question. So I kind of didn't do that as well as I could have, but you got it absolutely right. And even this minor point, the gustatory area of the insula. When we went through the lobes of the brain, I mentioned insula, but said we weren't going to do anything with it. And so we only really did frontal, parietal, occipital, and temporal. But there is this little thing, and it's buried down here in the Sylvian fissure. You know, that big fissure at the side of the brain. It's down in there, and it's a very small. It's a small little part. But it does get taste information. So I don't know how you got that. It's in a slide. I know it's on a slide in chapter 5, but I don't think it's in a slide in chapter 7. Does anyone know? Okay. Yeah, I don't think so. Okay, well, that's great. Any questions on that one before we move on? I didn't get to group 6, but I will start with you guys next time. And let's just go to let's look at the questions again and see if there's a particular one you want to look at as a group. Is any of these at all that you want to take a look at preferentially for the time that we've got left here? As I said, I did work them all out, and I'll put them in, post them after we're done. But any?
I think that the clinical implications is what really gets us.
Okay.
Like that's where well, for me, I feel like I'm stuck there.
Okay, so what we want to look at is number 2. Down here, signs and symptoms, right? That's what you're referring to. Okay. All right. Oh, actually, I do. This is the one with the answers. Yeah, well, okay, let's look at it. Okay. Let's take the first one, transection of the trunk of the right hypoglossal nerve. We kind of talked about that a few minutes ago, but you would see visible atrophy on the right side of the tongue, and the tongue would deviate to the right on protrusion. And does that one make sense to you all? Does anyone have a question or need a little more clarification on that one?
Would the tongue protrude towards the right because of the weaker side?
Yes, that's a good question, because some people, that's not immediately clear. If you got a weakness on the right side, how does the tongue, what direction does the tongue go? And you want to think about the tongue having, even though it's a single structure, it's got 2 sides to the genioglossus, which is the muscle that pulls the whole bulk of the tongue forward toward its point of origin, which is here, right inside the chin. I forgot what those little protuberances are called. Mental protuberances, is it? I'm not sure, but there's a couple little protuberances, and they originate right there, and then they pull the whole tongue forward toward this point. And so the way you would stick out your tongue is you use the intrinsic muscles to shape it, so it becomes like a pointing stick that you can get out there. Otherwise, it's just a big blob of flaccid muscle. So you shape it with the intrinsics, but you actually pull it forward with 2 halves of the genioglossus. So I'm just trying to work up to this point of what I'm going to say now. So if you protrude this side because it's strong, but not this side, what's going to happen is it's going to go like this. See, so it's going to deviate toward the weak side. And I'm trying to illustrate with my hands and pulling the 2 halves of the tongue forward with the genioglossus, which has 2 halves, innervated by cranial, by hypoglossal on one side and another hypoglossal on the other side. Does that make sense, how having a weak genioglossus on, let's say, the right side here is going to result in deviation to the right? Are you?
Yeah.
It does? Okay. So you see that tongue deviate to a side, that is the weak side. Then you have to figure out whether it's an upper motor neuron lesion or a lower motor neuron lesion. And this visible atrophy tells you right there, it's a lower motor neuron lesion. It does take a little while for that atrophy to develop. It takes a few weeks, actually, because if you went in and snipped a nerve, let's say it accidentally occurs in an injury or surgery, well, they'll be weak right away. They won't be able to protrude the tongue symmetrically. It's going to deviate to the weak side, but they won't yet have had any muscle wastage. It takes some time for it not getting any input from the neurons to start to atrophy. So the atrophy tells you it's lower motor neuron, and then it's been there for a few weeks. And the other thing is that if it's a lower motor neuron, like the snipping of the nerve, they shouldn't have any other problems. But if it's upper motor neuron, like a cortical bulbar tract, they're going to have probably, most likely, almost for sure, they're going to have other cranial nerves. They very well might have a contralateral hemiparesis, or the whole side of the body, you know, like we've studied. So that's going to tell you, oh, you get this kind of mix of all different things, tongue, part of it, but not the whole thing. And that tells you it's central, not peripheral. Okay. A functional transection of the left recurrent laryngeal nerve as it loops around the arch of the aorta. Well, I don't know if you guys have taken your voice class yet, 472, but when you do, one of the things they're going to drill into you is when you get a referral for voice, which you could do if you had a private practice, somebody has a voice problem, they hear about you and they call up and say, something went wrong with my voice, and can I come in? You always send to an ENT first. You don't even see them. You send to an ENT because of the possibility that they may have a laryngeal tumor or a cancer or an inflammation or something going on medically that is causing their voice problem. In this case, people get on the arch of the aorta aneurysms, and they're very dangerous. If you have an aneurysm on the arch of the aorta or any of those big vessels and it bursts, you're probably going to die, first of all. So you don't want to have that happen. And this, what happens is the aneurysm, which is a ballooning out of the artery, starts to grow bigger and bigger, and stretches the recurrent laryngeal nerve, which is stretching right under that loop. So it's actually, if you get an aneurysm in that location, which is a area where the aneurysm is prone to form because it forms more in arches than in straightaways. So it's not uncommon, and it's not uncommon for the very first sign to be vocal hoarseness. Well, then they go to the ENT, and the ENT is going to hear the hoarseness, as anyone would hear the hoarseness, but they're going to do a laryngeal examination and with a flexible scope. And what they would see is they would see the left vocal fold in the paramedian position. Now, paramedian means just off the center. It's not at the center. It's like it's not fully adducted, and it's not fully abducted. If you take a big breath real fast, you forcefully abduct the vocal folds so you can take in as much air as quickly as possible. Well, they can't do that either. So it's kind of like halfway in between. It's not fully adducted, it's not fully abducted. That's referred to as the paramedian position. And it can neither adduct nor abduct. So you say, that one doesn't move. It's the other one moves. And so that's what the ENT would see. They'd see that vocal fold on that side, left, it would be the left, because remember, this is a peripheral nerve lesion, and peripheral nerve lesions lead to ipsilateral signs and symptoms. Okay, so that we've got. And then a modified barium swallow, which we haven't done yet, but we will see some of them. Those will be some of your observational experiences, to look at people swallowing with a moving X-ray so you can see the barium going through and see what's happening. If a modified barium swallow, they would probably show aspiration, especially of thinner liquids, because their larynx is not able to fully adduct because of that recurrent laryngeal nerve lesion. So those are the three things. Everything else should be fine. You tongues at the midline, and the face is not drooping or anything like that. So it's a very isolated problem. You okay with it? No, Georgina's saying no. Does it not fully make sense? You're muted.
I'm going to hear it. I'm going to hear your recording again, so I can try to
Okay. All right.
process it. I think I'm just like, my brain is just like shut down.
Everybody's fried. Yeah.
Yeah.
I think we're probably doing what we should be doing here.
Yeah.
That is me going through it. Okay. You speak up, guys, if you have anything to add to it. But okay, Now, the next one is a stroke in the brainstem swallowing center. First of all, where is the brainstem swallowing center? It's in the rostral medulla, rostral being toward up. And it involves those two nuclei on each side, ambiguous and solitarius, and the surrounding reticular formation. A stroke that does just that, takes out just that, but they don't have a hemiparesis or anything like that, that would be a little stroke, but that is very possible to happen. I've seen many. And what happens to them is they usually they are walking around and they're complaining of kind of shortness of breath because they're aspirating their own secretions. And if you ask them, can you swallow? They'll say yes. And indeed, the oral part of the swallow is intact. The tongue's fine, the velum's fine, that's all fine. It's just the absence of a pharyngeal response. So if you go back to those slides and you get to the part where it's past the oral phase, and now we're into the pharyngeal, all that's gone. None of it happens. So they push it back there and it disappears. Where does it go? Well, it's not going to go through the upper esophageal sphincter, because in order to have that happen and get into the esophagus and go down to the stomach, in order for that UES to open, you got to do a bunch of stuff. You got to relax the muscle that makes up the sphincter. You've got to elevate the larynx, and you've got to close the vocal folds and close the false vocal folds, and even close the adytus laryngis, which is the opening into the larynx. You've got to close all that. And then you've got to squeeze it down with the constrictors, and tongue also does that. But none of it happens. So they'll take one little sip of water if you were to give them a tiny spoon, and it disappears and they think they've swallowed. But you listen, and now they were sounding wet already because they weren't clearing their secretions, and now they sound wetter. And they may cough, or they may not, but they'll begin to sound more wet. So the signs of that are vocal hoarseness, because it does involve voice too, to some extent. Usually, I someplace between usually and always. Everybody I've ever seen who has a stroke in that area and has lost the pharyngeal swallow response has been hoarse. And then they have an absent pharyngeal swallow response. And the way you do that is well, first of all, when you have a pharyngeal swallow, your Adam's apple goes up. Well, theirs doesn't. So they swallow it, it disappears from their mouth, but their Adam's apple didn't go up. Or if you listen with a stethoscope, which is called cervical auscultation, you can hear a little click when the pharyngeal phase occurs. You don't hear the click. So the other thing that would show up is they'll have wet upper respiratory sounds. And so you can even at bedside determine that they have no pharyngeal swallow response. And for that reason, we don't even do a modified barium swallow on that patient, because they really can't do the test. Keep in mind that if we've given them anything, it's been a quarter teaspoon of water, a quarter teaspoon. And probably, I don't think I've ever given such a person anything. I just have them swallow their spit, their saliva, which they can do because they're completely cognitively intact. They can follow commands, and they'll swallow their saliva and say, yes, I swallowed it, but you don't hear any click and you don't see any elevation. And if you're listening to the quality of their respiratory sounds up in this area, it gets wetter. Every time they try to swallow, it gets wetter.
Where is that food going?
Well, obviously it's not going down the esophagus. So if they were to keep their saliva is going, they're either spitting it out, which they can do, or once they know the problem, we give them this thing called a Yonkers suction, which is, it's just a vacuum tube with a thing that's about this long, and they just stick it into the corners of their mouth and around under the tongue and stuff, and suction out the saliva. And basically they keep their saliva to a minimum. And they as soon as they know what's going on, they want to do that because it's uncomfortable for them. They figured out that something's wrong. And they think they were swallowing, but then they learn that they're not swallowing. And it's going to go, if they took a glass of water, it would all go into their airway.
How do they eat?
Well, they don't.
Oh, they don't.
No, they don't eat. So
So probably in G tube or,
yeah, at first they would give them IV fluids
okay,
for up to maybe 3 days. And that doesn't give calories, but it does meet the fluid needs, which is the most urgent. You know, you become dehydrated if you don't drink anything or get any fluids for 24 hours, you'll be dehydrated. But as a well-nourished adult can do well with 3 days of no actual nutrition. So they'll try that for 3 days while we treat them for their absent pharyngeal swallow response. And we do have a treatment, or more than one treatment for it actually. And hopefully it comes back in 3 days. If it doesn't, then we go to what Mark said, which would be a nasogastric tube, and try for about 7 days of treatment. And if it still doesn't come back within 7 days, then they'll get a gastrostomy tube, which is through the stomach wall, because that's the least uncomfortable and the least dangerous of the options available. And then they would continue treatment and hopefully get that back.
Professor, I have a question.
Yeah.
So if a person is NPO and then they have them, so is the steps that it would be NPO first, and then they would get the nasal tube for feeding, and then it would be
They'd get the IV fluid for 3 days. Then the nasogastric tube for up to 7 days. And then
would a PEG or a G tube, because what's the difference between a PEG and a G tube?
they're the same.
Okay.
Yeah, they're exactly the same. 2 different names for the same thing.
Thank you.
Yeah, sure. It sounds like you know about them.
Well, I work in a hospital, and so
You know
there's
about
lots
them.
of NPO, G tube, and yeah.
Oh yeah, you
lots
know
of
all about it then. And you know about the IV fluids too.
Yes.
So those rules that I gave you, 3 days on IV fluid, 7 days on NG tube, and beyond that, the G tube. Those are rough approximations. It depends upon circumstances. For example, if a person came in who is already malnourished, as sometimes nursing home patients will come in and they're already at 70% of ideal body weight, we're probably not going to go through 3 days of IV because they're already in trouble and they don't have the strength to bring to bear on a recovery process. So they would get an NG tube right away. So those are just rough approximations. And some physicians like to go a little longer before they'll do a G tube, you know, hoping that it gets better. The risk of an NG tube is that they're very highly prone to aspirate the material that's going in through the tube, because the tube is compromising the 2 sphincters at either end of the esophagus. You got a big tube going through there, and it's not that big, but there's a tube going through there. So the sphincters, which are supposed to keep gastric contents from coming up and being aspirated, don't work as well. So they try to counteract that by keeping the head of the bed up at 45 degrees or more at all times. But it still can happen. Yeah. Okay, any other questions on that particular one? I'm glad you moved us on to these clinical ones. I think it was Renate, because they're interesting, aren't they? Okay, now a large stroke in the territory of the right middle cerebral artery. You can focus on just how you think swallowing would be impaired in this one, because you already know about the cranial nerves and how the body would be affected and everything. So it's just on how you think swallowing. Well, now I said focus on what? You can focus just on how you think swallowing would be impaired, but then I don't focus on swallowing. I focus on the cranial nerves. I'm sorry. Before I post this, I'm going to change the question a little bit so it fits the answer here. Yeah, I think you're not ready to actually go on to figuring out the swallowing part of this, but you are the cranial nerve. So I'm just going to change this and say, how does it affect cranial nerve functions? And you would have left, it's on the right side, and it would involve, since it's the whole territory, it would involve the internal capsule. And so you're going to have a left lower facial droop on the side opposite. Okay, and it's only going to be lower 2/3, not the upper. Okay, and then the tongue would deviate to the left on protrusion. I don't say anything about atrophy because there shouldn't be any atrophy, because this is upper motor neuron. And then you'll have absent response to light tactile stimulation over the left side of the face and oral cavity. Keep in mind, that's the whole left side. We're only dividing into lower 2/3 and upper 1/3 for motor, for muscles, not for sensation. Yeah. And it's actually a different cranial nerve we're talking about, but they all send their pathways for sensation up through the internal capsule. Okay. All right.
I'm confused with that one. So with the MCA, the internal capsule, you know, the MCA, right? We're talking about the MCA. How do we know that it's the left facial droop, the left lower facial droop? That's what I'm confused
Oh,
about.
okay. Okay. Well, when you damage the right internal capsule, it's going to disrupt cortical bulbar fibers. All cortical bulbar fibers for on that side. So it's just a matter of where are they going to go. And most of those are going to go to the side opposite. Now, when you get to the face, about 80% of them headed for the side, about 80% of them that are destined for the lower 2/3 of the face do decussate. If you're talking about the upper third, about 50% do decussate. So your forehead is going to be protected because it's an upper motor neuron lesion above the decussation of that system. And where's the decussation? At the level of the nucleus. So that
Okay,
accounts.
so the MCA is in the internal capsule. I'm like, right now, I'm like so fresh.
Yes, the MCA provides blood to not only to the whole lateral convexity of the brain, literally the whole side of the brain, the cerebrum, I should say the cerebrum, but also the deeper areas, including the internal capsule, the basal ganglia, all of that on that side. So you're interrupting. You're
Not the medial side, right?
Not the what?
Not the medial part of the cerebrum. That would be the anterior.
Well,
the
in terms of
the ACA.
in terms of the surface area, it's going to be the side of the brain.
Okay, the lateral convexity.
Correct.
Okay.
Yeah, I didn't mean to say. Well, I didn't
But the
mean
anterior cerebral artery covers just the medial aspect of the cerebrum.
Yeah, and the mid-sagittal fissure.
That's what I wanted to clarify. That just be like the lower extremities and things like that.
That's right. Lower extremities for both sensation and for motor.
Okay.
But those are the patients we never see.
Okay.
Because they don't have any communication or swallowing problem.
Oh, okay, that's a very rare. It wouldn't affect our practice.
That's right. I don't think it's so rare. I think you can have a stroke there, but PT sees them.
Oh, I see. Okay.
Yeah. Yeah, not us.
That makes more sense for them to see. Okay.
Exactly, because they're one of their main functions is to improve ambulation, walking and sitting and all that business too. Okay, so then the tongue's going to deviate to the left. Everything that's wrong is going to be on the left here. Okay, so the tongue's going to be deviate to the left. The loss of sensation is going to be on the left, and it's the whole side of the face, not just the lower 2/3. And also the oral cavity. How far back? To the oral pharyngeal port. Okay, so you look in there and you see the fascial arches coming down, and you see the posterior edge of the velum. That's the oral pharyngeal port. That's the boundary of the oral pharyngeal port. Okay, I thought I'd written perfect questions, but I did not, because there's one. Before I post this, which I'll do in just a few minutes, or I don't know if anyone's coming to my office hour. Is anyone coming to my office hour?
I would like to come.
Okay, well, as soon as we're done, I will post that before I do anything. I just have to change this a little bit to be correct. Okay, well, we've gotten to 20 till. I know you're all fried. I'm sorry about that. There's only one more episode of Being Fried in my class, and that's the last day, and you won't have to do anything afterwards. So that's the plus side. Okay. I'll say good night.
So it's gonna get, from this point on, it's gonna get easier?
Well, I think it is in the sense that, yeah, that the material that you've been studying up through chapter 7 is challenging. We all know that. And the material now for just 2 more chapters, we're only doing 8 and 10. And I'm going to probably have you read and write a little reaction to the pediatric chapter, but not much. And there's going to be no grade on it because we're not really going to cover that. We don't have time, basically. So chapter 8 and 10, which is motor speech disorders this coming week, and then language and cognitive disorders, where we study the aphasias, the right hemisphere syndrome or the minor hemisphere syndrome, and the cognitive communication deficits from traumatic brain injury and Alzheimer's disease, and those would be the common ones. So that will study, and we'll see examples. But yeah, the character of the material changes quite a bit now. To, I don't know what you've taken classes, you've taken 352. It's a lot like 352. You know, you're going to learn the characteristics of the communication problems that we experience, but you'll also know the parts of the brain that are involved, and then you'll be able to anticipate, you know, given that part of the brain being involved in causing this communication disorder, what else would I see with it? And when is there a mismatch? Sometimes you'll see patients, you think, well, that just doesn't make any sense. They must have 2 lesions or, you know, something. Yeah. So yes, it does.
I want to say I've learned a lot. I'm way smarter in neuroanatomy than I started.
Well, everybody has learned a lot. I know you have.
Yes.
Yeah.
And I think it's been a lot of fun.
I'm not sure everybody would say that.
Renate, I think you have fun with everything.
Yeah, I love having stress. It's a good thing.
Oh, well, good. You're gonna love working.
Right.
When they give you a full caseload that everybody's complaining about, we can't see that many patients. You know.
I'm used to teaching.
And you guys don't know how much work goes into a full evaluation, but a full evaluation is at least an hour. And I'm hearing about people, SLPs in hospitals, doing 7 full evaluations a day. Oh, that's a lot. I've done 7, but I felt it. But Renate, I think you'll fly through that because you love the stress.
Yeah, I love stress. Stress is good.
Okay.
What?
Okay.
Stress, I'd be lazy.
I'll see you all next week.
So, Dr. Kesselman, so I would want a private one. What time? We're right at 7 or a little bit?
We could actually meet right now if you want to.
Sure, that would be fine.
Okay, why don't we? Yeah. Okay, so I'm gonna go to the office hour, and then you'll have to knock on the door, and I'll let you in.
Of course, I'll go there now.
Okay.
Thank you.
All right. Give me a minute.
Thank you, Professor.
Thank you.
I have a question, Professor.
Yeah. Is that Evelyn?
Yes. There you go.
Okay.
Are you gonna be adjusting the grade?
Oh yeah.
Because
You must have missed it. Yes, I'll have grade adjustments made by tomorrow. I don't know how much because I don't know what the mean was yet until tomorrow morning. I'll get that, but yeah, I'll make sometime during the day. I'll do that.
Okay, because I study at all the PowerPoints, and I'll be honest, I feel like there was only a small amount of questions that were based on the PowerPoints, how you said.
Yeah, well, PowerPoints are the lecture.
Both.
Yeah.
Well, because when I say PowerPoints, I mean both, because I write notes
Oh, sure, yeah,
in the
yeah.
PowerPoint.
Yeah, well, I don't know. I sat there with the PowerPoint right in front of me and saying, that's number 17.
I don't
PowerPoint.
know.
I'm putting that into a question. So
Okay, well, I don't know. I was like, oh God, what
Yeah.
is this? What is that?
yeah, but of course it's in the different words. So maybe,
Maybe that's what threw me off because
Yeah.
I kind of, I guess, memorized your
Yes.
PowerPoints and
Sure.
the notes I took. So
Yeah.
probably that's the thing that threw me off. That if you change the wording,
Yeah.
I was like, wait, what?
Yeah, it's not that I intentionally changed the words, but we say the same thing in different ways all the time, and so
Okay, well, hopefully it goes up
Okay.
because
Hopefully.
my grade dropped and that does not look good.
Okay. Well, we can talk after we know the facts then.
Okay.
Okay.
Thank you,
Okay, Evelyn.
Professor.
Bye.
Bye.